the specialty that we now call structural heart disease in interventional cardiology. This was a definition that was proposed by Marty Leon back in 2006. And this was a result of the growing activity that was seen in pediatric and adult congenital heart disease and the availability of transcatheter heart valves. What Marty was seeing was there wasn't a training specialty for adult congenital and adult structural patients or the cardiologists that would treat them. So there was plenty of fellowships and so forth for cardiologists that were doing coronary arteries and things like that, but there wasn't anything related to this new developing specialty. So 2006 we get the proposal that anything that is in a congenital disease that reaches adulthood that's being treated with devices or treated with stents that is not a coronary artery disease fits under the heading of structural heart disease. And that's kind of a loose definition. The history of how it got to that place, I think you could probably go back to around the time of Bill Rashkind was an interventional cardiologist. He was probably the very first interventional cardiologist that treated congenital heart disease. He noticed that in many of these kids that are born with severely compromised blood flow between right and left heart, where they were having to do something surgically soon after birth, they take these babies and they'd have to do a thoracotomy, and then it'd open up the atrial septal defect, sometimes pretty traumatically. They didn't necessarily need cardiopulmonary bypass. So seeing this, he developed a balloon technique where he actually, when the baby was born, they would pass a balloon into the right side of the heart and across the atrial septum because they still had a hole there when they were just born, and then pull the balloon back to open up the atrial septum so that you had blood mixing between the right and left side. So that was the Rashkind balloon septostomy. That was sort of the first truly interventional device utilizing a balloon. Bill Rashkind went on to develop some other occlusion devices like the Rashkind umbrella, and that led to the development of a lot of these atrial septal defect closure devices that we see now. So the Rashkind single umbrella led to the double umbrella, and that was work from people like Jim Locke and Chuck Mullins and Bill Hildebrand all went together on trying to develop and formalize that whole area. It's interesting because the first, well, there's a lot of things in there. The first atrial septal defect closure device that was used clinically was developed by Terry King and Noel Mills in Louisiana, and they put the very first one in a patient, and they were successful. This is in 1975-76. It wasn't until 2001 that in the United States we had our very first FDA-approved atrial septal defect closure device. So it's been a long period of development of these devices. So as we talked about how, what do you use a balloon for? In the entire world of these structural heart conditions, the last 20, 30 years has been dedicated to developing the right kind of sheaths, the right kind of catheters and guide wires and balloons and all the technology around getting the support that was required to treat these conditions and learning the techniques and practicing those techniques. And that's been ongoing for almost 30 years. So we look at some of the people that have been involved in this kind of work over time. There's some notable folks whose names we should remember. Is people like Dave Nikkinen was using RF wires to be able to perforate the atrial septum, to perforate into vessels that were partially or completely occluded so that they could be opened up. To also use that same RF wire technique to connect between arteries and veins and to stent across those when they needed to create flow between the two of them. John Gibbs was pivotal and developed stents to keep the ductus arteriosus open so that they could maintain blood flow when they had poorly oxygenated blood. Neil Wilson, by contrast, developed the very first device to help close those ducts in premature babies where they had severely compromised circulation, but they needed to close the duct. Evan Zahn did a tremendous amount of work in neonatal stenting and stenting across very recent surgical anastomoses and showing that it was safe, that you could keep these vessels open and you could perform the procedures on very young babies. The development of transcatheter heart valves, I think two of the most notable names. One was Philipp Bonhoeffer, who developed the first transcatheter pulmonary valve, and Alain Cribier, who developed the very first clinically used transcatheter aortic valve. So these collection of devices for closure of septal defects, stroke prevention by closing the PFO or closing the left atrial appendage, transcatheter heart valves. Now we do aortic and pulmonary, and they're working now in the mitral and tricuspid valves. So I remember there was a lecturer who in the 2000s, early 2000s, said his prediction was that 65% of all surgical procedures, and I think it's much more now, could be performed by transcatheter procedures and transcatheter devices. And all of these need balloons to help them on their way.